Hi, my name is Nicole Juffermans. I'm an intensive care physician working in Amsterdam. And then on this section of co-infections in COVID, we will focus on invasive pulmonary aspergillosis, which I will call IPA, and reactivation of herpes infections. So during the pandemic, several studies have come out reporting a very high incidence of IPA in COVID of 26%. And this is putative IPA, so not proven because none of these patients in none of these patients, biopsies were taken or autopsies were done. So a putative pulmonary aspergillosis in 26% of patients. Although it isn't quite clear in all these reports whether all patients had undergone the same diagnostic procedures. This is another study performed in the Netherlands reporting a similar high incidence of 24%. But again, you can see that a bronchoscopy-guided lavage was only performed in a minority of patients. Well, this high incidence of IPA comes to mind that we've seen this before, of course, in another severe viral infection, and that is influenza. We've shown some years ago in this large case cohort study that the incidence of putative IPA in influenza is 19%. It's similarly high. And the presence of influenza was an independent risk factor for IPA in these patients on ICU. So the question is that is this IPA occurrence specific for some types of viral infection, or is it perhaps common in every sort of severe viral infection? And why could this be? Well, it has been noted in influenza patients that viral infection can cause severe ulcera of the respiratory tract, as you can see here. And this may cause an entry for the hyphen and for the aspergillus to enter into the pulmonary tissue and cause infection. Because as you know, it is common to be colonized with aspergillus in your oropharyngeal tract, but this should not cause disease. But if there is an entrance possible, and also the host immune response is decreased in COVID, this together may cause, risk factors for invasive infection. So the following questions come to mind. How should we diagnose IPA? What are the risk factors? And should we treat IPA in COVID? Bronchoscopy-guided lavage is recommended not only to yield specimens from the lower respiratory tract that you can send for culture, but also for detection of galactomannan with an optical density cutoff point of 0.5. The galactomannan has a high sensitivity of 86% for the detection of invasive pulmonary aspergillosis in a large cohort of intensive care unit patients. So not only viral infections, in all ICU patients. So this is a good method. But then again, bronchoscopy in COVID produces aerosols and can be considered a risk. There are two academic hospitals in Amsterdam. In one institution, bronchoscopy was not done in COVID, and in the other, bronchoscopy was done in every COVID patient. And you can see here that in the hospital that did bronchoscopy, 30% of pulmonary doctors contracted COVID versus none of the pulmonary doctors in the institution where bronchoscopy was not allowed in COVID. So I would recommend against the routine use of bronchoscopy in COVID. So can you diagnose then on peripheral blood samples? Yes, if you take a blood sample and you have a positive galactomannan in your blood sample, I think you can consider this proven IPA in COVID. But if your blood sample is negative, this does not rule out the presence of IPA in COVID, as 3 out of 4 patients with a positive galactomannan in bowel fluid had a negative galactomannan in their peripheral blood sample. So that is why we have constructed a non-directed bowel technique. And this is used, as you can see here, and you make use of a closed suction circuit to which you can connect a container. And by this, you can instill a volume of normal saline and then advance the suction catheter until wedge. And then you let the patient cough. So the patient should not be paralyzed. So let the patient cough. And if you yield non-transparent fluid, you can send it for culture. But of note, the patients can desaturate. So we think the intensivist should be in the room or perform this technique himself. So by applying this technique in a consecutive cohort of IPA patients that required mechanical ventilation, We had 53 of them, and 43 underwent BAL. One didn't yield a good sample, so we had 42 patients with a good sample. And of note, all of these patients had severe ARDS with pulmonary infiltrate, so all of them had clinical symptoms of infections, of course. So they applied to the clinical diagnosis of IPA. And in these samples, 21% of them had a galactomannan with an optical density cutoff point of more than 1 to be on the conservative side. So this yielded quite a similar incidence to the studies that I just showed you. In terms of risk factors, if you look for the classical risk factors for IPA, these are neutropenia, hematologic malignancy, stem cell transplant. We didn't have any patients with these classical risk factors. We did find a higher incidence of COPD in patients with IPA versus those without IPA. And also of note, the patients with IPA had a higher disease severity as reflected by higher Apache 4 disease scores. So what about steroids? We didn't administer steroids in these patients because we did this diagnostic study prior to the publication of the recovery trial. So none of these patients had received steroids. Why? Because we were aware of the association between steroids and the risk for IPA in severe influenza. Because the odds ratio of the risk for IPA in influenza, if you use steroids, is 2.1. So whether steroids are a risk factor for IPA in COVID is not known at this point in time, but I can't imagine that it would be anything different than for influenza. So then should IPA be treated? There are no data on that also, so there are only opinions. I will share some opinions with you. In this study, authors described also a similar incidence of IPA in COVID as I've shown you, and they stated, we believe COVID patients with a positive BAL or serum should be treated. The Dutch guideline, which has appeared recently, said you can consider treatment when the BAL is positive, but we don't see an indication for prophylaxis. And this is a statement by our Belgian colleagues, and they stated, well, we've taken the approach of prophylactic nebulization with amphotericin B in all of our COVID patients. So my personal opinion would be that it's prudent to screen for IPA, and I think a non-directed BAL technique, although not validated, is a useful option in COVID because bronchoscopy is too dangerous. I would not withhold low-dose steroids because of the recovery trial. But if IPA is present, I suggest a short-term treatment course. So now over to the reactivation of herpes virus. We always think about herpes simplex, but cytomegalovirus, CMV, is also part of the herpes family. So it's normal that you become CMV seropositive during your lifetime. About 17% of us have been infected with CMV, but normally this does not cause disease. However, if you have severe inflammatory reaction or severely ill in ICU, this predisposes you to CMV reactivation. As shown here, that Apache disease score is associated with CMV reactivation and also high lactate, C-reactive protein, but also the use of high dose of corticosteroids, again, a risk factor for CMV reactivation. So what about ARDS? This is quite a large cohort of patients with 70% of them being CMV seropositive. This reflects the general seropositivity of the general population. In these patients, blood samples were taken and a PCR on CMV was done. And if this is positive, there's active replication. And you can see that during their time on ICU admission, the number of patients which have active replication of CMV increases over time. And these are these green areas reflecting quite a high percentage of ARDS patients whom display reactivation of CMV. So related specifically to COVID, we know already that COVID presents with lymphopenia. And in this study, this lymphopenia has been characterized. And you can see that all types of lymphocytes are depressed. Also the CD4 T cells, CD4 and CD8 T cells are severely diminished. But not only is the count low, also on CD4 and CD8 cells, in COVID, they display markers of exhaustion, meaning that probably their function is also deteriorated in COVID. So this poses a problem not only to the clearance of SARS-CoV-2 virus, but also to the clearance of other viruses, such as herpes simplex or cytomegalovirus. So using the same diagnostic approach that I just showed you with the use of non-directed ball lavage of COVID patients on mechanical ventilation, and we've had a little bit of a higher number of patients here because we did the study later in time, and these data have not yet been published. And what we found using this non-directed ball technique is quite a high reactivity of herpes simplex in 12% of patients. CMV reactivation we found in 10%, and a small number of patients had 5% had reactivation of both these viruses. So in terms of outcome of patients with CMV or HSV reactivation, also their Apache disease score was higher, and their ICU length of stay was higher in patients with reactivation versus patients without reactivation. ICU mortality was similar, but of note, we opted to treat these patients with antiviral medications because we also administered steroids to these patients. So with this, I would like to conclude. I've shown you some evidence that putative EPA is quite frequent in COVID, and also reactivation of herpes virus is detected in COVID, and this is associated with increased disease severity. At this point in time, I think it's not possible for anybody to determine whether the pulmonary infiltrates that you see are due to COVID or are due to these severe superinfections. But I think that as we know now that COVID patients display an immunosuppressive state at some points, and also because we administer steroids, it is my personal opinion that you should screen for the presence of EPA. I think the non-directed ball technique is feasible, or you can consider serum or so blood samples. And if you find any presence of EPA or herpes reactivation, I suggest that you consider a short treatment course. And with this, I would like to close, and I would like to thank you for your attention.